Okay, it looks like our attendees are leveling off, so we're going to go ahead and get started. Um, Thank you for coming and attending tonight's talk on our virtual health talk series, Know Your Colon Cancer Screening Options. Before we get started, we're going to go over some of the housekeeping details. Just so you know, this is on virtual. You will not be able to actually be on video or ask questions verbally. So the way you'll ask your questions for our presenters tonight is to open up the Q&A button in the toolbar, and then you type your question in and click send. If you wish, you may select an anonymous button so your name isn't posted with the question. Also letting you know this webinar is being recorded. Everyone who does register will receive an email follow-up with a link to the video to go watch it online. And you can also share that obviously with friends and family as well. All right, so I'd like to introduce tonight's presenters to you. We have two board-certified gastroenterologists from the Digestive Health Institute. Our first presenter tonight will be Dr. Brooke Glessing. She is the medical director of the Digestive Health Institute at Hoosier Medical Center and the director of endoscopy at Cleveland Medical Center. She is also assistant professor of Case Western Reserve University School of Medicine. Her undergraduate was from University of Notre Dame. She did her medical education at the Minnesota Medical School, along with a residency at Hennepin County Medical Center, and then fellowships in gastroenterology and advanced endoscopy at the University of Minnesota Medical Center. Also presenting tonight is Dr. Greg Cooper, who is the co-program leader for cancer prevention and control at Seidman Cancer Center. He is the program director for gastroenterology at Cleveland Medical Center and the co-program leader for cancer prevention and control for Cleveland Medical Center. He is also a professor at Case Western Reserve University School of Medicine. His undergraduate is from the University of Pennsylvania. He did his medical education at the University of Pennsylvania School of Medicine, and his internships, residency, and fellowships were at University Hospitals of Cleveland. So welcome, presenters. We'll hand it off to you for tonight's talk.
Okay. Sorry, just a few. Okay. Well, thank you everyone for being here tonight and spending your evening with us talking about colon cancer screening options. It is a subject that both Dr. Cooper and I hold very dear to our heart. It is so important that we talk about it, that we get the word out there, and that we become comfortable talking about it. So the two main colon cancer screening options that we're going to be talking about tonight are colonoscopy and stool-based tests. There are a few other screening options, mainly radiology-based, that are they're for very specific people and are, not generally something that we would offer for or recommend for the general population. So colonoscopy and stool-based tests, I will be focusing on colonoscopy, and then Dr. Cooper will be talking in greater detail about stool-based tests. But first, I thought we should just review the anatomy and where is the colon in our body. So the colon and rectum are actually the last part of what we call the digestive tract. It's also referred to oftentimes as the large intestine. And so, the digestive tract is one continuous entity. It starts at the mouth, esophagus, stomach. It goes down into the small intestine, which then empties into the colon. And then once the small intestine goes into the colon follows a pretty predictable course. It goes up, across, down, around, and out through the rectum. The rectum actually is the last 4 to 5 inches of the colon. And the colon, a lot of people ask me, how long is that colon? And it's generally about 4 to 5 feet long. It may be a little bit longer in taller people. But this is the area that we're doing colonoscopies on, and this is where colon cancer can form. So, if we do a colonoscopy, it starts we start at the very outlet, the anus, and we can actually advance a scope all the way around the entire colon and evaluate the inside, the mucosa of the colon. So now that we know where it is, what exactly does the colon do? So the colon functions it has 4 main jobs, but it functions to really absorb extra fluid and nutrients from the food that we eat. And then as that content passes through the colon, it begins to store it as waste. And as it passes, as the stool forms, it then gets stored in the rectum and then can be passed out of the body through stool elimination. Okay, so now that we know what the colon is and what it does, what are these colon polyps that we keep hearing about and talking about? And really, colon polyps is so important to understand what they are, because they are the whole basis of why we do colonoscopies and why we are concerned about the formation of colon cancer. So colon polyps are these abnormal growths of tissue that form on the lining on the inside of the colon and rectum. This is just a schematic showing kind of what a cartoon of what a normal colon would look like. And these are the little polyps. They can range in size, but oftentimes are really small. They are less than ½ of an inch in many cases. So very, very small. I sometimes equate it to the example of like a skin tag on the outside of your skin. So very, very small. And the majority of polyps are actually benign, meaning that they are harmless. But the issue is that some of them will continue to mutate and then develop and grow into colon cancer. So these are just a few examples of what polyps can look like. These are all polyps that were seen at the time of colonoscopy. And as you can see, they all do have sometimes different shapes, different morphologies, different sizes. They can be pretty subtle. There's one right here. There's another larger one here, still very, very small. This is magnified quite a lot during the colonoscopy. But all of these have the appearance of being pretty benign, sessile. This one is a pedunculate. These are all just terms that we use in our colonoscopy report to really describe the polyp. The one here on the right side actually is much larger. It looks kind of like it has multiple different polyps all together. This one is definitely larger, definitely more concerning. It was a benign polyp, but certainly would be something that would have grown and continued to have probably mutated into a colon cancer. So colonoscopy, so what is it when we're talking about colonoscopy? So colonoscopy is the procedure where we can actually use a thin, flexible tube with a camera and a light source, and we can look inside your colon. Like I was showing you before, we can evaluate the entire colon. We can even pop into the small intestine. And it is a procedure, it's a day procedure. You come in, it is painless, you are sedated. It takes about 30 minutes for the procedure, a little bit less, a little bit more, depending on what we're seeing and what we're doing. After the procedure, we awake you from your sedation, and then you go home about 45 minutes later. You do have to prepare your colon with a bowel cleanse a day before the procedure. And what is so important to understand about colonoscopy is that it is the only one of our colon cancer screening methods that not only can we detect colon cancer, but we can actually prevent it. These pictures on the right are actually real pictures from patients. They were given to me from my partner, John Dumont. And both of these polyps, were found completely incidentally during the patient's screening colonoscopy. This one is a smaller polyp. This one is a much larger polyp. Both of them, though, can be removed at the time of the procedure. We use various different equipments and methods, but the most common is this equipment. It's called a snare, and it's a little kind of wire lasso. We put it around the polyp and then just snip it off. And so the benefit of a colonoscopy is that, like I said, a lot of these polyps, this may never become a problem, but we don't have a crystal ball. We don't know if it will or not. And as we're doing the colonoscopy, we can actually just find it, get it out of there, and we can kind of nip it in the bud. That polyp never has the opportunity now to become a problem. And we can do that for small polyps as well as larger polyps. So colorectal cancer. So there are different stages of cancer. At stage 0, actually, it's not cancer, it's just a polyp. Just like the two polyps I just showed you, they begin as, again, these little growths of cells, and you remove them, and those polyps will never have a chance to become cancer. That is what the goal of colonoscopy is to prevent cancer from even starting. Stage 1 cancer, as you can see in this little schematic, you have the start of cancer within that polyp, within that growth of tissue. You have the beginnings of cancer, but it's completely contained within the polyp. within the colon. When found at this stage, we can actually still remove it during the time of colonoscopy. And when found, 9 out of 10 people survive and it never becomes a problem. Stage 2, you have the cancer within the polyp and it has spread just beyond maybe the immediate lining of the colon. But still, this is considered still very early detection. And again, when found early, 9 out of 10 people will survive. When you get to the later stages, stage 3 and 4, this cancer now has spread beyond the wall of the colon into either the lymph nodes, which can then, the lymph system can then spread those cancer cells to other parts of the body, where it can then take rest in other organs. And when you get to the stage 3 or stage 4, that is when you get concerned about, what we would call later detection and needing potentially chemotherapy or other methods to treat the cancer. And you have a lot, 7 out of 10 will survive a stage 3. And if it's found later, you have maybe 1 out of 10. So what do these polyps look like? This is stage 1 and stage 2 examples of polyps. This one, is actually a stage, it's an advanced adenoma. So it's a stage 1. Everything is completely contained within this polyp and it can be endoscopically removed and treated at the time of colonoscopy. For these malignant polyps here, these are actually both stage 2 polyps. Again, they are early detection. So we are finding them early before they have spread beyond the walls of the colon or rectum. They can be removed and high survival rate. Okay, so I wanted to throw out some colorectal cancer facts. These are so important to just get ingrained in your head because they're so important. So colorectal cancer is the second leading cause of cancer-related deaths in the United States when you combine cancer deaths for both men and women combined. 90% of new cases will occur in people 50 years or older, although we are seeing it presenting earlier in the, and so the current screening guidelines have actually changed in the past couple of years to have now recommended that we start screening people, all people of average risk at the age of 45. 80% of new colorectal cancers are actually diagnosed in patients without any family history of colon cancer. And people with a first-degree relative, I'm talking about parents, siblings, your children, anyone that has a first-degree relative who has had colorectal cancer now has a 2 to 3 time risk of developing colorectal cancer. A lot of people ask, so what are the signs and symptoms of colorectal cancer? So they can include things like change in bowel habits. You may have diarrhea, constipation, something different than what you usually are doing. You may feel that your stools you really aren't emptying your bowel. You go to the bathroom, but you just feel like you still have something more that needs to come out. Sometimes people describe that their stools are more narrow than usual. You may see blood, like bright red blood, or even black, kind of tarry, sticky stool. Some people get gas pains or cramps. They might feel bloated or full. They might start feeling like they can't eat the same amount that they used to eat. They might get nauseous. You might just start feeling like you're really tired or that you're losing weight unexpectedly. So these are all signs and symptoms of potential colorectal cancer. But what I would like to impress upon you is that 7 out of 10 people that are diagnosed with colorectal cancer have absolutely no symptoms at all. And the symptoms that I just mentioned, they may be signs or symptoms of colorectal cancer, but they actually could even be signs or symptoms of other GI issues. So if you have any of these symptoms, we would recommend that you talk to your primary care doctor, that you seek out a gastroenterologist or someone that you can talk to, a healthcare provider that you can talk to about these symptoms, so they can evaluate you further and then make the appropriate referrals to, either a colonoscopy or other workup. But again, the majority of people that have colorectal cancer actually have no symptoms at the time that's diagnosed. And polyps are just in general completely asymptomatic. Little small polyps, usually you will never know that you have them until we actually take a look. So what are risk factors for colorectal cancer? So there's things that you can't change. So how old you are, your race, your family and personal history, your genetics, those are things that you can't change. Things that you can change that may affect it would be physical activity, what you eat, your weight, and then obviously if you're being proactive and getting screened. Ways that you can reduce your cancer risk, what can you do? So you can quit smoking, you can eat a diet that is high in fiber, fruits and vegetables. We know that activity is good for your general health, but also good for your colon. You know, getting to a really healthy weight is good, and then limiting your alcohol use. But by far, the most important thing that you can do to reduce your cancer risk is to get screened. The benefits of screening, again, is that we can remove polyps during colonoscopy. It decreases your chances of ever developing colorectal cancer. And then if we detect cancer early through screening, we can really greatly improve the chances of long-term survival. Right now, 1 in 3 adults are not getting the recommended screening. And so I'm going to now introduce or leave it to Dr. Cooper to talk to you more about other ways that you can get colon cancer screening besides colonoscopies.
Okay, well, thank you, Dr. Glessing. That was a great overview. So I'm going to talk a little bit about what we call home-based testing, which are essentially different stool tests that can be used to screen. And Dr. Glessing showed you pictures of polyps. I'm not going to go over them in a lot of detail, but this is a little polyp. Who knows if it's going to cause any problems down the line. But I'll say right now, this will not show up on a stool-based test. There's no signs of bleeding in it, and most of this test look for blood. It's small. So this is something that if you do a stool-based test, we're probably not going to be able to find. Next slide. This is a much larger polyp. This is still benign, but this would have a much higher chance of progressing to cancer if it was not removed. But this sort of polyp would hopefully show up on a stool test because, as you can see, there are some signs of bleeding with it. Next slide. And this is a colon cancer. This looks very nasty, and this is something that we'd like to prevent. But as Dr. Glessing mentioned, occasionally we do find these at the time of colonoscopy. And this obviously would show up on most of the stool tests that we do. Next slide. So I'm a gastroenterologist. I make a good part of my practice and living doing colonoscopy. So why am I talking about stool tests? Well, one of my mentors many years ago, quote, it was my favorite quote, the best screening test is the one that gets done. So we have a whole menu of options for screening. While I'm going to believe that colonoscopy is probably the best test that we have available, I'm not naive. I realize that not everybody wants to get one. So I think it's better to do some sort of screening rather than doing anything at all. So really, if colonoscopy is not the right test for you, I'm going to talk about some of the other tests that are out there. Next slide. Okay, so what are the pros and cons of stool testing? Well, it's certainly more convenient. You can do it at home. Many patients, not the majority, but there are patients who have issues with colonoscopy. You have to be able to have a ride to take you back and forth to the hospital. You have to undergo the bowel prep, which is, if you ask patients who've had it done, is the least favorite part of the procedure. And then the procedure is done very safely, but there is a small chance of complications, bleeding or perforation. They're 1 in several thousand, but they can occur. And I think the tolerability of the procedure is much better in the fact that we give intravenous sedation, but there are patients who just don't like the sedation. So people have issues with colonoscopy. The downside of the stool testing is that because it's not as accurate as colonoscopy, it has to be done more frequently, typically somewhere between 1 and 3 years. If you do have a positive stool test, we can't tell you what made it positive. You could have a polyp, you could conceivably have colon cancer, but you could have hemorrhoids causing bleeding. So we don't really know why the test was positive. And then that leads me to the last point, is that if you have a positive test, you need to get a colonoscopy. So when your provider offers a stool-based test, you have to understand that if the test comes out positive, the next step is a colonoscopy. We can't really skirt the issue. Next slide. There are patients who probably should not get stool testing. If you're having blood in the stool, most of the stool tests, actually both the stool tests that we use do pick up blood in the stool. So if you're seeing blood in the stool, there's no point in doing a stool test. You should go straight to colonoscopy. If you have a family history of colon cancer, Dr. Glessing mentioned that it increases your risk, and those patients should go to colonoscopy because they're a higher risk. And if you've had polyps removed in the past, you should also go straight to colonoscopy because your risk is higher. Next slide. So these are the two stool tests that are out there. The first one is called FOBT, or the guaiac test. This is something that's being done less and less frequently, but for those of you who've had it done in the past, what's done is you're given these cards to take home with you. There's 3 cards here, 1, 2, 3. Each of them is supposed to be collected as a separate bowel movement. Use the spatula to smear it on these windows, and then you bring it back to your provider's office, who adds this developer to it, and in the presence of blood, the back of the card turns blue. Next slide. The test that's being done more frequently now for stool-based screening is called FIT, fecal immunochemical testing. It's a one-time sample, so you don't have to do 3 consecutive bowel movements, and it's actually a stool that's collected. You swab it, you put it in this tube, and you bring it back or mail it into your provider's office. Next slide. So both of these tests look for presence of blood in the stool. If you're going to do the first test that I showed you, the guaiac test, it's recommended to do it at home with 3 consecutive bowel movements. I think it's being done less and less frequently, but there are still some providers who may opt to do it just on a rectal exam in the office. It's certainly, you have a captive audience there. You can do the stool test then, but it's thought to be much less accurate. The FIT test is preferred because it actually measures hemoglobin directly. Hemoglobin is blood, and so it's thought to be more accurate. The guaiac test, the older test, can be affected if you eat red meat, or there's certain foods that can give you a negative test. It's less affected by diet. And also the problem with any of these tests is that if it does show up blood, you're not sure where it's coming from. It could be coming from your stomach, it could be coming from your lower bowel. Although it's thought that the FIT test is maybe a little bit more specific for the lower bowel, blood in the colon, as opposed to the upper GI tract. Next slide. But in its defense, the guaiac test, the FOBT, has been shown to decrease colon cancer mortality in people who are getting screened. The U.S. trial was done in Dr. Glessing's alma mater at University of Minnesota, and they showed that in people who got annual testing, you were able to reduce colon cancer mortality by 1/3. There were 3 studies done in Europe with lower mortality reductions, but the tests were being done less frequently. So it does work. It is done. The FIT test is thought to be more sensitive. It picks up about 70 to 75% of cancer. So still not all of them, but the majority. But it's less sensitive for big polyps, only about 20 to 30%. The FIT test is done more frequently than the colonoscopy, every 1 to 2 years, although most people would say every year. And I'm going to show you on the next slide a picture of a different type of polyp called serrated lesions, and FIT is very bad at picking these up. So these are polyps that really scare us as people who do colonoscopy. These are called serrated adenomas. And if you look on the left, these are 2 pictures of these lesions. The top one just maybe look like some mucus that's sitting in the colon. The bottom picture looks like maybe a fold in the colon, but on the right-hand side, when you use what's called narrowband imaging, which is a blue light as opposed to a white light, they stand out much better. You can see that, in fact, these are really lesions. They're not just artifacts. And these lesions are not only hard to see at colonoscopy, but they almost never bleed, so they're not going to be picked up at a FIT test. They will be picked up in patients who have Cologuard testing that I'll talk about in a minute. Next slide. So before I talk about Cologuard, the question that always comes up is, why don't we just do blood testing for colon cancer screening? I think if I asked everybody in this audience, would you rather have a stool sample submitted or have somebody draw your blood? I suspect the majority of people would rather have blood tests. It's certainly less messy, so to speak. But the problem with the blood test is that it's only going to show up as a rule if you have an advanced lesion. So on the top of the picture, you see different stages of cancer, starting with precancer and then progressing, as Dr. Glessing talked about, through stages 1 through 4. And you can see that the blood test only really shows up when the cancer is pretty far advanced, if it's invading into the bloodstream. On the other hand, stool tests on the bottom will, because what's done technically is that the lab collects the stool. They're able to separate out the cells that are shed from the lining of your colon. It's actually pretty nifty technology, and they can look for different markers. And these will show up potentially even in a precancerous stage as well as an early stage cancer. So at least in 2021, now there are blood tests that are being developed. Stool tests will win every day. Next slide. So what is involved with Cologuard? So if your provider orders a Cologuard, it's a kit that's sent to your house. It comes in a box, and inside the box, there's this bucket, which is where you collect bowel movement. So with the FIT test and the FOBT, it's actually a smear of stool. With the Cologuard, it's a whole bowel movement that you collect that goes inside this bucket. There's a device that sits on the toilet that the bucket sits underneath. And then the thing in the liquid is a buffer. It's added to the stool sample to help stabilize it. And then there's also a FIT test, just same as that FIT I showed you earlier, that's part of the kit. So you collect this at home, and then you send it off to Exact Sciences, which is the company that does Cologuard, and they analyze at their facility. So if you do a Cologuard test, I always tell my patients two things. First, make sure you screw the lid on real tight. You'd be surprised how many people don't do that, and things leak out where they shouldn't. And then the other thing I tell people is when the UPS man comes to pick up your sample, probably better not tell him what's in there, just for his own peace of mind. Just tell him it's going to a lab. Next slide. So the way Cologuard works is it's two different components. There's 3 different molecular markers that are done. And I'm not going to go into the details, but they're genes that are mutated in colon cancer. And then there's also a FIT that's part of it. So there's a FIT plus these 3 molecular markers. Now, when a Cologuard test comes back, the lab will tell you if it's positive or negative. They don't tell you what's positive. So they won't tell you if it's positive because you had blood in the stool or if it's positive because you had one of these markers or both. But we do have pretty good data with Cologuard. There's a study that was done several years ago that enrolled about 10,000 people who were average risk for colon cancer. And they all had both FIT testing and Cologuard. And then they all went on to get a colonoscopy, which was the gold standard. And look at the next slide. You can see how the two things compared. So Cologuard picked up about 90 plus, I think 92% of cancers. So the vast majority. The FIT testing did okay. It picked up 70 to 75% of cancers, but not quite as good. Cologuard also outperformed FIT for detecting large polyps, although still the majority of large polyps were not seen on Cologuard, but a smaller percentage was seen on FIT. And then the SSAs, the sessile serrated adenomas, the picture that I showed you earlier, these are the lesions that are very hard to see because they don't bleed and they're very subtle. Cologuard actually did pretty well, better than you might think for picking up these large serrated lesions, as opposed to only about 5% for FIT. Next slide. So Cologuard, again, has improved cancer detection over FIT. It detects about 40 to 50% of precancerous lesions. The other advantage of Cologuard is it's done less frequently, but because it's more accurate than FIT, it's done every 3 years as opposed to every 1 to 2 years. The main, one of the downsides of Cologuard, though, is that we have what are called false positives. So these are patients who have a positive Cologuard test, then go on to a colonoscopy, which is the recommended follow-up, and have absolutely nothing significant at colonoscopy. These tend to occur more in the elderly for a variety of reasons. And the other downside of Cologuard compared to FIT is that it's more costly, although insurance generally covers both procedures. Next slide. So we were interested in seeing, this is a study that we recently did in the UH experience. I mentioned that patients who have a positive test need to get a colonoscopy. So we're interested in seeing actually what is the follow-through with colonoscopy. And we looked at over 300 patients that have positive FIT, another 300 some odd patients that have positive Cologuard. And unfortunately, a lot of patients did not follow through with colonoscopy. Less than half of those who had a positive FIT had a colonoscopy within 6 months, and about 75% or so who had a positive Cologuard had a colonoscopy. So still not as good as we would like. And the irony is that when these patients did go on to colonoscopy, almost half of the patients who had a positive FIT had either precancerous or malignant lesions, and even a higher percentage of those who had a positive Cologuard. Next slide. We then looked at the medical records to figure out why these patients never had a colonoscopy. And as you can imagine, the reasons are all over the place. Patients often didn't show up for their procedure. They refused the procedure. They had other health issues that are going on, et cetera. And I think one of my biases is that when a provider gives a patient a choice and patient's out for a stool test, they'll often pick the stool test because they don't want to get a colonoscopy. But I think the message has to be, if you have a positive stool test, the next step is a colonoscopy. There's really no way around it. Next slide. And then if you just compare the two stool tests, to sum up, both tests measure hemoglobin or blood in the stool. The Cologuard measures genomic markers as well. They're both approved as screening tests. If you look at the labeling for FIT tests, there is no restrictions on it, but I would argue that it should be done in people who are average risk, not do it in people who are having symptoms, not do it in people who have a family history or a prior history of polyps, whereas Cologuard specifically says it's only limited to average risk people. The recommended interval we talked about, 1 year versus 3 years. The kit distribution for FIT is done either in person from your provider's office or mailed from the local lab. Cologuard is mailed from an external site. And then the kit return is the same, either in person to the lab or to the external site. One of the things that Cologuard does, which may improve its compliance, is that the company actually calls the patients afterwards who don't return the kits to sort of bug them to send it back in. There's no such recalls, at least on a systematic basis for FIT. The good news, as I mentioned, is that insurance covers both of them for Medicare. There's no out-of-pocket cost for either test. But if you are paying out of pocket, you can see that there's a huge cost difference between the two. So Medicare is paying a lot more for Cologuard than FIT, but it does have certain advantages. Next slide. So I think just to sum up with what Dr. Glessing said, is that screening for colon cancer can prevent precancer, can detect precancer as well as early stage cancer, and thereby save lives. If you think about other cancer screening that we do with mammography, we're potentially detecting early stage breast cancer. We're not really preventing breast cancer, whereas colonoscopy, we're actually preventing cancer because we're removing precancerous polyps. Colonoscopy is the most accurate test and allows for polyp removal, but I would argue that if you don't want to get a colonoscopy, any of the approved tests are acceptable, with the caveat that if you have a positive stool test, you need to get a colonoscopy. As Dr. Glessing mentioned, screening is now recommended for most patients over the age of 45, and we do it even earlier if you have a family history and certainly symptoms. So we used to, just a last point is that back in the day when we would see somebody who was young, who was having rectal bleeding, we would often say, oh, it's probably hemorrhoids, and if their labs are normal, we wouldn't really do much else. But now we're seeing more cancers in younger people in their 20s and 30s. Many of them don't have a family history or other risk factors. So the recommendation now is if you have a young person who's having bleeding, that it should be evaluated. So I will stop there, and then we can turn things over for questions.
Okay, that was really great, Greg. Thanks so much. I wanted to just end a little bit real quickly with one of our patients. He's actually a dear friend. This is Steve. He has over 29 years of endoscopy experience. He has been a nurse for over 25 years. He is currently actually a nurse here at Ahuja Medical Center in our DHI department in endoscopy. And despite the fact that he is been surrounded by colon polyps, by patients that have been found to have colon cancer on their screening colonoscopies, and he knows what a colonoscopy is, and he knows what goes into it and how quick it is and how easy it is, he still had so many reservations when it came time for him to do his own colon cancer screening. And I remember talking to him at the time and just saying, I don't understand what your hesitation is. Why would you not want to do this? And so I wanted him to, and he did get screened, but I do want him to tell you, kind of share his experience, because I think it is something that a lot of people can relate to, and just kind of hear it from him. So this is Steve.
Hello, everyone. So as Dr. Glessing said, I've been in endo for a long time. And the thought I had was, why do the colonoscopy? Because everybody's got to die of something. And I see where people get older and they start getting forgetful and all the crazy things that go on with being older. And I thought, why should I get old and have my kids mock me? And people were saying, Steve, your kids are already mocking you. And the physicians were saying to me, Steve, you should die of something better than colon cancer. I mean, it's a horrible way to die. I mean, the pain and all the things that go with that. So I didn't think much about it. And I have adult children and both of them live out of state. One's in Oregon. And then when my daughter, she's the younger child, she moved to Florida. And I saw my wife very sad. And when I'd come home from work, she's like, oh, I'm so glad you're home. Boy, all the things of being an empty nester, missing your kids. And so I decided I'm going to do the colonoscopy for her because I can't leave her alone. She's a great lady, and how could I do that to her? So I actually chose to do the screening colonoscopy for her. And it was painless, I have to say, and it was very easy. I had my peers even take care of me. I know people were saying, oh my gosh, how could you have your coworkers taking care of you? Wouldn't you be embarrassed? And I thought, I'm going to have the best of the best. And I truly mean that. I always say, if I woke up in the ICU bleeding to death and I saw any one of my colleagues or the physicians who I work with taking care of me, I would go back to sleep knowing that I'm in the best hands ever. So that's a little bit about why I didn't want to do it and then why I did it. So back to Dr. Glessing.
Thank you, Steve, so much for sharing your story. I really, really appreciate it. And then before we open this up to patient or to questions, and I just want to quickly a lot of people have been asking me, like, what are we doing with colonoscopies during this COVID age? And I just want to really reassure you that, we have really changed our process. We have taken extra precautions. We are having all of our patients get COVID screened just prior to their colonoscopy. The majority of people that are working in healthcare are now vaccinated. We have done all extra kinds of measures to make sure it is a very safe experience for you. And then as far as university hospitals, we have made it as seamless and as easy as possible to get scheduled for colonoscopy. So we have what we call open access colonoscopy scheduling, where you don't need to get a referral to come in. You can just call in and make yourself an appointment. Okay, and so with that, I will end.
Thank you, Dr. Glessing and Dr. Cooper, and thank you, Steve, for sharing your story. Just for everyone, if you have a questions for Dr. Glessing or Dr. Cooper or Steve, you can type it in the Q&A. It's down in the toolbar on your Zoom. You'll type your question in there and we'll read it and have them answer it. So without further ado, our first question tonight is, if I have a polyp removed during colonoscopy, can I still use a stool sample test for my next check?
I can take that. So it's recommended not to. And the reason is that once you've been diagnosed with polyps and have polyps removed, your risk of getting polyps back is going to be higher. So generally about 30% or so of the population, maybe higher, maybe lower, will get polyps. And there's something in your makeup that makes you more likely to get polyps, whether it's your genetics or your lifestyle over the years. And so that puts you at a higher risk. So it's recommended that you not opt for stool testing afterwards. The other issue is that, as I showed you at the beginning, most of the smaller polyps and even some of the larger polyps will not show up on a stool test. So you could very easily have recurrent polyps and have a negative stool test and kind of get a false sense of security. So we strongly recommend that if you've had polyps removed, and there are types of polyps that are not considered precancerous, so that's a different story. But if you've had precancerous polyps removed, you should be put into the colonoscopy window. Now you don't have to come in that frequently. In most cases, it's 5 years or more before your next colonoscopy. It's only if you have very large polyps or polyps with certain features under the microscope that are more worrisome, and then you come in sooner. But most cases, it's 5 years plus, so it's still not that often.
Great, thanks. Our next question is, after what age is a colonoscopy no longer recommended?
That's a great question. We generally will continue colonoscopies until at least the age of 65. And then between the age of 65 and 75, we really take it on a kind of individual basis as far as, taking into consideration the entire patient and what's going on with their health. And then we also take into consideration what your previous colonoscopies have shown and what your risk factors are. Do you have anything to add to that, Greg?
No, I think it really depends. I think that's really the key is what somebody's longevity is and what their previous screening is. The recommendations are certainly after age 85 not to do anything, but there's a gray zone once you get 75, 70, 75 plus, and it really depends on your overall status.
Great. Our next person says, my mom had colon cancer which was caught early, and she's still alive over 25 years later. Her mother passed away from colon cancer in her late 60s. I am 67. Am I at high risk? If so, how often should I have colonoscopies, and should I do any other screening tests? The last colonoscopy I had was 4 years ago, and a precancerous polyp was removed.
So I can start, and Brooke, you can chime in. But so basically, if you have a first-degree relative with colon cancer, so that's a parent or a sibling, you should start screening at a younger age. So typically, instead of starting at 45, starting at age 40, and then going more frequently, typically every 5 years, even if they don't have polyps, as opposed to every 10 years. Now, in your case, if you're 67, you should still be, assuming that you're in good health, you should still be in a screening or surveillance program, we call it. And especially if you had a polyp removed in the past, assuming that it was a small polyp, the recommendation would be to come back in a year or so. So if your last colonoscopy was 4 years, come back at 5 years. And then your risk is still, because you have a first-degree relative, your mom, and a second-degree relative, your grandparent, your risk is still, elevated. So you should still come in for more frequent screening. There's really, in your case, there's really no other testing that needs to be done. Now, if it may not be make that much sense at your mother's age, but back in the day, she could have had genetic testing to see if she had one of these higher risk syndromes. But in your case, it's probably not recommended since you haven't had any major findings in your colonoscopies. Do you have anything to add, Brooke?
Yeah, no, and I just wanted to reiterate that just for the general population, again, we are now recommending that we start screening at the age of 45. And if you do have a family history of a first-degree relative with colon cancer, we recommend that you start earlier at the age of 40, as Dr. Cooper just said. But if you have a first-degree family member that had early onset colon cancer, they were younger, we actually recommend that you start 10 years before they were diagnosed. So if they were diagnosed at the age of 40, we would actually have you start earlier. But again, 45 for the general population, and earlier if you have a first-degree relative with colon cancer.
Thank you. Our next question is, when the polyps are removed, how is it determined whether they are benign or malignant?
Oh, that's a great question. So when they are removed, we actually are able to capture them, and then we send them to pathology, and then they run special tests on the polyp to determine what type of polyp they are and what their precancerous risk are, and then we follow up with the patient following that. It can take up to a week for that pathology to come back, and so we always tell you that at the end of your colonoscopy that you'll be receiving some sort of communication from us regarding just kind of closing the loop on what that polyp was. Next
person asks, how soon before a colonoscopy should you be altering your diet and not eating certain foods, should you stop taking any supplements or vitamins?
Yeah, that's a great question. So typically what we recommend is that for a few days before the procedure, not to eat high fiber foods, just because fiber, I mean, everybody says fiber is great, and it is, but before a colonoscopy, fiber is more difficult to clean out. So typically for a few days, we have you stay away from things that have seeds or skins, things that are harder to get cleaned out. The day before the procedure, you're just on a clear liquid diet. So you're just basically drinking things that you can see through. Some people, and this is the trend now, not everybody's doing it yet, are allowing people to have like a very light breakfast the day before the procedure. So just like maybe like a poached egg and white toast, but certainly nothing whole wheat, no heavy meals. And then if you're taking iron supplements, that tends to be the biggest offender. You need to stop that typically a week before the procedure because of the iron kind of coats the colon, is more difficult to clean out. And then the other issue, if you're on any kind of like blood thinners, or you'd have to check with your providers to see whether those could be stopped or not before the procedure.
And then the only other thing I would add to that is if you do have diabetes and are on insulin, we do often recommend that you talk to your doctor who's managing that. You might need to change your dose of insulin, just because you will not be eating nearly as much food the day before the procedure or the day of the procedure. And so a lot of times we will have you take a half dose of insulin. But that's also patient dependent, so just something to think of. We used to have people stop taking aspirin, and that is no longer a recommendation. So if you're on an aspirin for your heart or whatever, you could just continue taking that.
Thank you. Our next question is, if you have no polyps, does that imply no chance of future cancer? And if you have no polyps at every colonoscopy?
So it would really depend on what age you are. So if you have a colonoscopy and you're pretty, let's say you're getting it now and you decide to get one at age 45, there's still a chance you could develop cancer later in life. So you should still come in every 10 years. If we were talking about earlier, somebody who's older, let's say you're 70 and had a totally normal colonoscopy, then you probably have a very low, not zero, but a very low chance of developing colon cancer later in life. And that's assuming that you have no other risk factors like family history. The other thing is that you have to assume that the clean out is good. So when you have a procedure done, you'll get a report, and they'll usually tell you how good your prep was. So if your prep was good, that increases your confidence that that you can have some reassurance. We have patients, unfortunately, come in, even if they follow things to a T, for whatever reason, they don't get cleaned out very well, and then they'll need to come back sooner just because we can't be confident they didn't have anything.
One of the things that I don't know if we really mentioned, or I don't think I mentioned it during my talk, was that the reason why the recommendation for colonoscopy in average risk patients that has no polyps found at the time of colonoscopy is 10 years later, so every 10 years until it's deemed no longer necessary, is because we know that the pathogenesis or the development from a polyp to cancer generally will take 10 years. And so if you have a colonoscopy and there's no polyps found, then the assumption is that at some point, if a polyp does form within that time frame after your colonoscopy, and you come back 10 years later, we will still detect it before that polyp has hopefully grown into or developed into a cancer. Am I saying that correctly, Greg?
Yeah.
Okay.
Great, thank you. Our next question is, how often should a colonoscopy be done for individuals over 60?
It's exactly the same as what the guidelines are. Again, depending on what your personal risk is and your family history, and if you've had anything prior to age 60, if you're coming in for your initial screening test at the age of 60 and you have no risk factors, no history, and you have a completely normal colon, we would say 10 years. If you do have polyps found at that time, then the follow-up would depend on how many polyps and how big they were. Does that answer the question?
I believe so. And the next question is, can someone without a family history have a colonoscopy before the age of 45?
Yes, the guidelines right now are.
Yeah, go ahead. Yeah.
Go ahead, Greg.
Oh, no, I was just going to say that, yeah, so 45 is the starting age. The only time we would do it sooner is if you're having symptoms. So if you're having change in your bowel pattern or rectal bleeding, or on blood work you found to have anemia, we would do it at a younger age. But right now, it was lowered from 50 to 45 fairly recently. So I don't think we're able to get it through below the age of 45 unless there's other symptoms.
Great. I think we've had a follow-up here from our person who had the colonoscopy and the polyp removed before. They're saying that he had a precancerous polyp removed twice, and the next test is scheduled in 18 months. Is that reasonable?
So you mean the follow-up colonoscopy from his last colonoscopy is 18 months follow-up. I'm assuming that the reason why it's a shorter time interval is because either the polyp was a larger polyp, or the bowel prep was maybe not as optimal as the endoscopist would have wanted, and so that's why they're bringing them back in 18 months versus like a 3-year interval, if I'm understanding the question correctly.
Great. Our next question is, I was 6 years old before I had my first colonoscopy. My doctor was upset that I had never gotten one because my father was diagnosed with colon cancer in his late 40s and died at 51. I've been told after my procedure, you are clean as a whistle, and was told to come back in 10 years. How have things changed in more recently?
So we realized that even in the setting of a normal colonoscopy, if you have a family history, particularly if your relative was diagnosed at a young age, like your father was, you should come in more frequently, because there may be situations where the things progress at a faster rate, and if you have a relative who's diagnosed at a young age, your risk is even higher than if they were diagnosed at an older age. So I think even with a normal colonoscopy, my practice is to have people come back in 5 years, even in the setting of a normal colonoscopy, and that's assuming that there's no other high-risk genetic syndrome.
Thank you. Our next question's a little bit of a complicated issue. The person says, I am high risk for a procedure because of 16 years of heart issues. I do have my 4th ICD-CRT-D. I also have issues with potassium loss, so I take high doses of daily and gastrorosis. So sorry if I botched that pronunciation. So I bloat badly in with the cleanse liquid. My only colonoscopy 20 years ago was clear, but now that my heart issues have escalated, I have a fear of having a bad prep and having something go wrong since I'm now 70, but want to live longer life without worry of getting colon cancer.
Those are all really valid concerns, and you're not alone is what I would say. I don't know if you, in that question, if you wrote any family history, but it sounds like your last colonoscopy 20 years ago was normal. And, what I would recommend is that you talk to, a gastroenterologist or, your primary care doctor a little bit more about this, but you would be a candidate if you haven't had polyps, so you're not high risk for, one of the stool studies that Dr. Cooper was talking about. But I will also say that we do many colonoscopies on patients just like you, but we do want to spend some extra time with you if a colonoscopy is something that you do want to pursue or to find out more about. But you would probably be a candidate for other colon cancer screening. Greg, anything?
Yeah, and the other thing is if you're on, I mean, many times patients with heart problems are on blood thinners like Plavix or Brilinta, drugs like that. So you'd have to talk to your provider about whether those could be stopped before the procedure or whether they need to be continued. Because that would also impact sort of how the procedure is done.
We have another question. Had a cecal adenoma removed in 2008, and biopsy just indicated adenoma, nothing about benign or pre-malignant. Subsequent colonoscopy was negative. Should the adenoma have been more specifically described? And how often should I undergo testing again? I was 57 at the time of diagnosis.
You know, you bring up a really great point, is that a lot of times, sometimes in medicine, we forget that we're using terminology that isn't very clear. So adenoma is the pathology, is a type of polyp that is precancerous. It is that type 0 lesion that was on that chart earlier in the presentation. And that's there's different versions of adenoma, but adenoma, villus adenoma, those are all precancerous types of polyps, but they are technically benign. So they're benign, they're harmless, but they are precancerous. And so when you got that pathology report describing it as an adenoma, that was supposed to also mean that it was a precancerous lesion.
Thank you. We have another question. Person had a colonoscopy at age 60, 2 benign polyps removed, polyp free at 65 and 70. So when would be their last colonoscopy?
That's a good question. So it would really depend on their overall health. So the recommendation is to stop, in somebody, particularly if you've had negative colonoscopies, to stop routine screening at about age 75 or so. But so if you had a negative colonoscopy at age 70, technically you wouldn't be, even if you had a polyp before, if your last 2 were negative, you wouldn't necessarily have to come in until you're 80. And 80 is sort of in a very gray zone. And so it really depends. So I would say probably next colonoscopy would be at age 80, unless there were other issues, unless the polyp you had in the past was high risk for some reason, or the prep wasn't good. But start coming back at age 80, which is a gray zone. So you'd have to sort of look at that point what kind of overall health you're in and whether it's worth going through a colonoscopy or not. So it's really very an individual decision.
Thank you. Looks like one follow-up to the adenoma. It says, how often should that person be screened?
I'm sorry, the adenoma where there was a question of whether it was precancerous or not?
Right, they're following up and asking how often should they be screened?
Okay. That's a good question. It depends a little bit on how many, if there was only that one and how big it was. A lot of times we're bringing patients back in 5 years, 7 years, if depending on how big of I forgot how big that polyp was, or if there were others. But probably 5 years is what I'm gonna.
All right, thanks. Just for clarification, can you just cover again, for an insurance purpose, what usually is covered between all the screening tests?
So really any of them should be covered. So Cologuard is not 100% covered right now. It's getting closer to 100%, but there are still a few carriers that don't cover it, but certainly Medicare and most of the other major insurers cover it. FIT testing is covered. Colonoscopy is covered starting at age 45, although I will say that since the 45 thing is fairly recent, there are a few insurance companies that still only pay for screening starting at age 50. So you'd have to check with your insurance company before you schedule. And then, so those are really the 3 major ones. So really any of them should be covered, assuming that they're done at the right intervals.
The other thing that I don't know, Dr. Cooper, what your experience has been with positive Cologuards that then go on to needing a colonoscopy, but I know some of my patients have had trouble getting that follow-up colonoscopy that is recommended, that is needed, following a positive stool test to get that completely covered as well. And so that might be something else if you're trying to debate, to talk to your insurance company about what they will cover if you proceed with the stool test. And if that comes back positive, if they will cover then the follow-up colonoscopy that's needed.
Yeah, that's an excellent point. And there's still a loophole with certain insurance companies where it's considered so insurance companies, but because of under Obamacare, are required to cover anything that's recommended for prevention. So whether it's colonoscopy or Cologuard or FIT, without any kind of out-of-pocket expense. But when you have a positive stool test, it then becomes a diagnostic test for the colonoscopy as opposed to a screening test. And then some insurance companies try to play hardball and don't necessarily cover it. So yeah, I agree. If you're debating, you might want to check with your insurance company to see if it's covered or not. One piece of good news though, I think it's fixed. So Medicare had this crazy loophole where even if a patient was coming in for a colonoscopy for screening and they had polyps removed, it was considered a diagnostic exam, and the patient somehow had an out-of-pocket expense at that point, even if the test was being done in somebody without symptoms for screening. That very recently got fixed, so you can thank our legislation for that. So if you do have polyps removed, it should be covered in full if you're under Medicare.
Great, thanks. And just a clarification, Dr. Glessing, on your recommendation of 5 years for that patient, they're asking if that's after initial diagnosis.
Yes. And, I feel like I don't have all the information. And so I'd be more than happy to, talk to this patient off screen or, in the office. But generally, the guidelines actually just changed not that long ago as far as what our surveillance for finding polyps. So it used to be in a very, very general sense. If we found a couple polyps and they were small, we'd bring people back in 5 years. If we found a bigger polyp or mini polyps, we'd bring them back in 3 years. The guidelines just changed a little bit. So if you have one or two really small polyps, sometimes we can wait 7 to 10 years before bringing those patients back. But without knowing the specifics about this polyp, I hesitate to make a strong recommendation on when that follow-up is, but usually 1 polyp, 5 years is what the recommendations had been.
Yeah, thank you. And anyone who has further specific questions, we encourage you to call the numbers on your screen there. Press 2 to get an office appointment. You can schedule appointments with Dr. Cooper or Dr. Blessing. Again, we thank everyone for their time tonight. Just a note from our heart patient that you convinced her to move forward for her family's sake. So great job.
Oh, good to hear. Okay.
Great to hear.
Any closing comments, doctors?
No, I like what we say.
Yeah,
You can prevent colon cancer, and
yeah, and we got in just under the wire. March is Colorectal Cancer Awareness Month, and today is the 31st, so we beat the end of the month.
But colon cancer can be diagnosed any month, so go get your screening.
Yeah,
true. Whenever you get it.
Yeah.
All right, thank you all for attending. Again, this will be recorded and posted on our website, and everyone who's registered will receive a link to watch it again. Thank you for your time tonight. Good night.
Thank you, everyone. Good night.
Thank you.